On episode 738 of the 40 Plus Fitness Podcast, we meet Dr. Nitin Yerram and discuss kidney cancer. Welcome to the 40 Plus Fitness Podcast, the largest and longest running health and fitness podcast dedicated to people over 40. Whether you're looking to lose weight, get stronger, or improve your health and age better, this podcast is for you. I'm your host, Coach Allan, an online health and fitness coach and author of the Wellness Roadmap. Each week, we dive into practical tips, expert advice, and inspiring stories to help you take control of your health and fitness. If you're ready to look, feel, and perform your best, no matter your age, this podcast is the perfect place to start. Let's get you on the path to a healthier, fitter, and more energetic version of yourself. I hope you'll join us each week, and together we can unlock your full potential. Hello, and welcome to another episode of the 40 Plus Fitness Podcast. I'm your host, Coach Allan. I'm really glad to have you here today. As this episode is coming out, I should be recovering from a radical nephrectomy, which basically means that they had to take out one of my kidneys. And so that was done last week, and this is coming out. It just happened to be, I don't know, serendipity, happenstance, whatever you want to call it, that a publicist happened to reach out to me to connect me with Dr. Yerram. So I'm really excited to be able to share this conversation with you. The incidence of kidney cancer is happening younger and younger. And we're going to talk about one particular case that kind of highlights this. But obviously, my previous co-host, Rachel, if you'll remember Rachel, her husband, Mike, also had kidney cancer. So as you can imagine, this has been kind of top of mind for me for a while now. But I just want you to know this episode is not intended to be medical advice. Okay, we are sharing some information that's just for your information. So you can just have more awareness of this disease and what to be looking for. And then if you do happen to ever have to deal with it, just give you some basic stuff to think about and things to start your research. But it is not medical advice. So if you do have problems, you need to be talking to your urologist and getting medical advice from them. Our guest today is a clinical expert with expertise in the treatment of cancers of the prostate, kidney, and bladder. He is an expert at the minimally invasive surgery, specifically using the Da Vinci robotic surgical to perform for robotic prostatectomy, that's prostate removal, robotic partial nephrectomy, and robotic cystorectomy, bladder removal with urinary diversion. In addition, he specializes in focal therapy for treatment of prostate cancer and offers eligible patients bladder-sparing treatment options for treatment of invasive bladder cancer. He is a prolific researcher in urologic oncology and has authored numerous publications and presented at national conferences, including the American Society of Clinical Oncology Annual Conference. As Director of Urologic Research, he offers patients state-of-the-art treatments and technology as a part of the Hackensack Meridian Clinical Trial Network. He received his medical degree from Northwestern Feinberg School of Medicine in Chicago, Illinois. He performed his internship in general surgery and urology residency at the Cleveland Clinic in Cleveland, Ohio. He received his fellowship in urologic oncology at the National Cancer Institute, National Institutes of Health in Bethesda, Maryland. With no further ado, here's Dr. Yerram. Dr. Yerram, welcome to 40 Plus Fitness.
Alan, thank you so much for having me.
So the topic we're going to talk about today is kidney cancer. Become apparent in a minute why this is actually so very important to me. But it also recently hit a major news story. Anyone that grew up and really liked kind of the music scene in the 90s would know the band Three Doors Down.
Mhm.
I certainly did. Their
Yeah,
albums.
right. Yeah.
The CDs are actually sitting on my player right now. But the lead singer, Brad Arnold, was only in his 40s, and he recently passed. He started with kidney cancer and it spread. Um, this just seems to be kind of a thing. More and more cases, earlier and earlier cases, because kidney cancer is typically something you don't get diagnosed with until you're well into your 60s. Um, I was recently diagnosed, and I'm just now 60. I wouldn't necessarily call that early diagnosis by any stretch, but it just seems that this is a lot more common than maybe I was aware before I started paying attention.
Yeah. Well, Alan, first I want to say I'm sorry to hear that you were diagnosed, but I'm really hopeful that your prognosis is excellent, and I think that's kind of one of the good news about renal cell carcinoma is in general, if you look at the whole scope of the disease, the prognosis is good if caught early.
Yeah,
And I think to your point, you're mentioning that people are being diagnosed earlier and earlier. We're seeing this, I call it an epidemic, across the field of medicine, of earlier and earlier diagnoses of cancers in this population, not just renal cell carcinoma, but also colorectal carcinoma, colon cancer, breast cancer. And I'm not sure we have a reason of why this is being diagnosed earlier and earlier. I'm
yeah,
sure there's some element of better screening and better detection. That's definitely one aspect of it, but I'm not sure that's necessarily answering the whole other side of the picture of why they're young men and women being diagnosed in their 30s and 40s of these cancers that are typically seen more in ages 60 to 70s.
yeah. Now, kidney cancer is an interesting one. Because it's one of those things when I mean I can look at what I found, and I think my case might be unique to me. Of course, some people are going to experience what I experienced, but there was a lot to it that I was like, okay, I really don't know how long I've had kidney cancer because it's not like there's a you wake up one morning and there's the light, like a red light on your dashboard that's blinking, and you're like, oh, I should probably check that out. How does someone usually find out that they have kidney cancer?
Yeah.
And what are the symptoms that I guess we generally should just be looking for?
So kidney cancer is obviously it's a tumor of your kidney, right? And for most times, for most people, that's a quite asymptomatic disease. It's not something that they're going to feel with the pain. A lot of patients come in, they say, "Oh, I'm feeling pain. I'm really worried I have a tumor." It's really unlikely that's the case. A lot of these tumors, for kidneys specifically, are found actually in incidental findings, meaning they get a car crash and they're just getting scanned, or maybe they have some indigestion and they're getting an ultrasound in their abdomen, whatever it might be, for essentially various unrelated reasons, they're getting some type of imaging of their abdomen, and they're noted to have a kidney mass. And then that further goes down that realm of diagnosis, and that's how you essentially discover that they have something in your kidney. There are a few symptoms that people tend to have, and one of the most important symptoms is blood in their urine, and that can be both something visibly seen in their when they're urinating, or also microscopic hematuria, which is hematuria is a word for blood in your urine, and that's where you're actually seeing yellow urine and it looks normal, but when they go to the doctor's office and they're looking under a microscope, they're actually seeing red blood cells in your urine, and that can be typically not that's not common to have that, and not everyone who has microscopic blood in their urine necessarily has kidney cancer, but it could be an early sign of it, and that's why something that we do tend to work up and learn more about for patients who do have that.
Yeah, that was what that's what got my attention was
Okay.
blood in the urine. Not microscopic. Let's just say it looked
You
like
actually
murder.
had what we
Uh,
call gross hematuria, right? Which
yeah,
is where you're
yeah,
actually seeing red urine, right? When you're
yeah.
urinating.
It,
Yes.
it it would look like I killed something when I went to the bathroom. I'm like, okay, I
Yeah.
should I
Time
should.
to go see a doctor. Yeah.
Now I had a couple of other symptoms that I think may have been early. I'm not say earlier, but they were definitely happening earlier than this. I had noticed that my blood sugar was creeping up. I hadn't really changed the way I eat, but my blood sugar response was slightly different, and my blood pressure would have a tendency at times to kind of spike a little bit here and there. and it was sporadic. It wasn't like my blood pressure was always high. It's just occasionally I would have
Sure.
this thing. Um, was that related to this, or maybe something I should have been paying a little bit more attention to beforehand?
Yeah, I think those are pretty what we would call non-specific symptoms, right? Blood sugar dysregulation and blood pressure dysregulation could be somewhat related to these to a kidney tumor, but it's honestly it's hard to say for sure they're related. But I think it emphasizes an important fact, right? Where if we feel like something is out of sync with our bodies, and it doesn't always mean that there's something wrong and we need to go get CT scans and MRIs, and that's not what I'm saying. But what I think it means is we should really talk to a primary care doctor and really be kind of tied in and really kind of have that discussion with our physicians who take care of us, because when they do see something that's maybe out of whack or a little bit out of sync, I think it could just be a small symptom of a broader problem, and I think it just emphasizes that aspect a bit more.
Yeah. When I was starting to go through that, obviously you stand in the toilet and you're like, okay, this is not normal. And so I was like, okay, I gotta figure this out. And so I started working with a doctor, a general practitioner, and we were looking I said, okay, I went and bought a blood pressure machine. So I'll come and check my blood pressure regular. And I noticed, okay, it gets really high, and then that's typically when I would have an issue. And I was like, okay, maybe it's just my blood pressure. Let's try to manage that. That was the first stage. And then it was my doctor here. I had another doctor here that I met with, and she's like, I just kind of want to do a scan. And we did a epidural. And I could
Probably
tell,
an abdominal ultrasound,
yeah,
it's
ultrasound. Yeah.
probably this, right?
I'm
Yeah,
sorry,
abdominal
ultrasound.
ultrasound.
That's the word. I was okay. I was just thinking back to pregnancy because the last time one of these was used in my presence was with my daughter, 30 something years ago.
Sure.
And so it's, kind of one of those things I could tell the doctor was a little, I mean, the radiologist doctor that was doing the scan, I could tell he was not happy with what he was seeing on my left kidney. I try to make a joke a little bit out of it, just to kind of lighten the mood. He didn't like the joke, but it was like, is it a boy or a girl? I thought it was a good joke, but didn't it fell flat. But my audience of one just didn't really enjoy that joke, which is, humor is kind of one of those things. Is the way I kind of step into a lot
Yeah.
of stress events.
Yeah.
Um, so now,
Well, I'll tell you, Alan, before you move on, yeah, I think just to talk about one of the main symptoms as we talked about, which is blood and urine that they're actually visibly you're seeing, it can be quite scary, right? I mean, I think
yeah,
imagine the amount of times you urinate in a day, and over the many years you've been doing it, and all of a sudden, what you expect to see normal yellow urine, and you see blood, and you're like, something is wrong, right? And I will say for females, it can be a bit more common, and not super
yeah,
common, but more common, because they tend to experience more urinary tract infections, and blood in their urine could be a symptom of a urinary tract infection. Males typically do not have a higher incidence of urinary tract infection, so it's not something we commonly see routinely. And so whenever I think men see it, they're like, "Oh my gosh, that's super scary."
yeah.
Um,
Well, one of the reasons I didn't go straight to kidney problem was, okay, I knew my blood pressure was up, and I was like, okay, my blood pressure's up. I went and got like a kind of a general overall blood test, to
yeah,
kind of check things, and my kidney numbers came out
fine.
okay.
Yeah,
And so there was nothing there like in my blood tests to say
yeah,
anything. Now I think obviously I didn't need to go get a urine test to say there was blood in my urine. That was evident. But it was just one of those things saying, okay, we're trying to eliminate the things because it was funny. I was having a conversation with my wife and she's like, we should probably get PET scans every year. And I'm like, no, we should not get PET
no,
scans every year. Uh, I think we can overanalyze, overscan
yeah,
as much as we could probably under analyze and underscan. And that's probably the biggest challenge of all of this is to say, okay, I have to pay attention to myself. And when things are not right, I have to go through a methodical process to figure out what's there. And there's actually a standard of care, it just walks you through.
yeah.
So we find this mass in a kidney. How do we know that it's cancer?
Yeah. So let's just step back for a second. I think there are multiple types of masses in a kidney, right? So there's solid masses, and there's cystic masses, and they're just cysts. So not everything that's on a kidney is considered cancer, and that's super important to understand. The vast majority of people that come into my office with something on their kidney, it could just be a simple cyst. A simple cyst is just a fluid-filled ball that they have in their kidney. And obviously on an imaging scan, it can look like a tumor because it's round and it sits on the kidney, but the reality is it's just a fluid-filled cyst, and there's nothing to ever worry about in those scenarios. And very, very rarely, almost never, do those ever turn into anything worrisome. So there's really nothing to ever worry about those things, and that's a good thing. So and cysts occur all sorts of places in the body, the liver, and even on your skin, and all sorts of places. So these are just fluid-filled balls that really don't necessarily mean that there's something wrong with anything. Then when you flip to the other side, there's the solid masses, which is typically what we're talking about when we say kidney cancer. And those are, essentially solid, and they're typically can be round or in different shapes, and they can either occupy a small part of the kidney or they can take up a large part of the kidney. And just to emphasize one point you made in the just a bit earlier, you mentioned my kidney numbers were fine, and that really didn't indicate anything about the cancer itself. And that's because the human body is a true miracle if you think about it, right? We have two kidneys, so even if this was maybe affecting your kidney in one way, your other kidney was compensating and had really no effect to your overall body in terms of the ability to clear all the toxins from your body is what a kidney does. So when going back to the solid mass, there are a variety of different types of solid masses, but for the vast majority of the time, and I'd say around 80% of time, when you have a solid renal mass, they typically are kidney cancer. Now, there are different types of kidney cancer in terms of how they look morphologically under a microscope. So there's clear cell carcinoma, there's papillary cell carcinoma, but they all fall under a large bucket of renal cell carcinoma. And some are more aggressive, some are less aggressive, but in general, they're all kind of, like I said, fall under that bucket of cancer. And probably for the most part, in that 80% bucket, they should have some sort of treatment. Again, that's not 100% the case, but that's probably the vast majority of times you do want to deal with that type of disease with some sort of treatment.
So, obviously, once something like this happens, you kind of look back and say, okay, what did I do wrong?
Yeah,
Okay, because
yeah,
this, it's hard for me to think cancer is a normal thing. It's not part of. I mean, it is part of me, I guess, biologically, but it's not me. And so it's almost like you feel like you did something wrong. Are there risk factors, the things we do or about us that we should be looking at, and that particularly those that we can actually do something about?
yeah. Great question, Alan. I think this answer is very complex, right? And so in short, renal cell carcinoma, talking about renal cell carcinoma specifically, right? We know the biggest risk factor for anyone to have is having family history of this disease in their family, right? So there are large families that tend to have these unknown genetic mutations, some known, some unknown, and the penetrance of that disease is very apparent in those families. So if you have family history of kidney cancer, you are at extremely high risk to having kidney cancer compared to the normal population. The other major risk factor that I think we've been shown is smoking, right? Smoking, and I think it's like the gift that keeps on not giving, right? So in addition to lung cancer and colorectal cancer and all sorts of other cancers that smoking does, smoking can also put yourself at risk for renal cell carcinoma, so kidney cancer, as well as bladder cancer and ureter cancer, and all sorts of cancers where the urine is flowing out of your body, because all those carcinogens are essentially making direct contact with that tissue, with the kidney, as well as the ureter and the bladder, and as it empties our body. So those are all very high risk factors. There's a lot of talk about kind of environmental factors, chemicals, and microplastics is kind of the newest thing now. I think there's a lot of exciting information about what that type of what those types of exposures have in terms of cancers, but I think the jury's still out. We're still in that early phase of understanding what the environmental factors have to do with this disease, my gut tells me there's probably some aspect and some relationship. There's no doubt. But what exactly that relationship is, I don't think anyone really knows for sure. But what we do know for sure is the two things that I just mentioned is family history as well as smoking.
Okay. Neither of those were big deals for me, but I'd read somewhere, maybe I misread somewhere, because again, I've done, as you might imagine, done quite a bit of reading on this,
I
is
bet.
that obesity and blood pressure also play a role in this.
Yeah. Do you want to repeat that, Alan, just so that?
It was obesity and blood pressure also play a role in kidney cancer.
Yeah. Let's speak to the first one. Let's say obesity, right? So I think obesity in general is something that is caused, for a variety of different reasons and habits and whatnot. But it essentially means there's a lot of inflammation in someone's body, right? And so, can inflammation cause cancer? I think the short answer is we think so, but we don't know 100%. But what we can know for sure is it's definitely not good for our bodies, right? So is there a direct link for obesity to cancer, at least for kidney cancer? I don't know if there's a direct link right now, but there sure has to be some sort of a secondary link associated with it. The other thing is hypertension, right? Again, I don't know if there's a direct link to hypertension to kidney cancer. As far as I know, there is no direct link. But when we talk about dysregulation of our bodies, right, are we able to, making sure we're staying in sync, staying healthy, and keeping our bodies without inflammation? I think there's no doubt that that's somewhat related. Blood pressure is going to be a part of that. I think there's some exciting data that got published probably within the last 1 year of people on GLP-1s, right? So these are like the Ozempics of the world. Those patients tended to get better response from chemotherapy when they're obese and they're taking these medicines. And that's an interesting concept, right? So they're saying that you're losing weight, and so these are people probably obese and are already on GLP-1s, and they for whatever reason got diagnosed with cancer, but they think they tend to do better. And I suspect a bit of that has to do with inflammation, and they're losing all that inflammation, and which I think is overall helping the body. So again, it kind of speaks to that same fact. If we take care of our bodies, right, I think it will help us in so many different ways. And cancer treatment and honestly prevention is going to be one of those major ways as well.
Okay. So now look, we find a mass, um, and the doctor said, okay, it's definitely a solid mass. Because like
Yeah.
I went through the ultrasound to see that there was a mass, and it was relatively large. And then come back and we did a CT scan with
Yeah.
contrast. Stuff didn't taste nearly as bad as I thought it would, and then the IV and everything, but it wasn't unpleasant. It wasn't like an MRI. This was not as
Quick.
unpleasant as an
A CT
MRI.
scan is quick.
Yeah,
Yeah.
and it was pretty quick. Gave them a lot of good information, but even from that, we don't really know. I don't. We know what it's not. It's not a cyst. We know it's solid. We know where it is and how big it is. But what are the other ways that we would be able to know how serious this is?
Well, CT scan or some type of cross-sectional imaging, whether that be a CT or an MRI, is really getting your best idea of understanding a couple different things, right? So you want to tell if a cyst is a mass. You want to be able to tell if a mass is solid or cystic, and something that's very clear on those imaging. We also want to be able to understand, is this gone beyond the kidney, right? And the way you actually are able to tell that is you look at the tissue around the kidney, you look at tissue around the major blood vessels, the lymph nodes, and if they seem to be enlarged, that's a concern that maybe this cancer spread beyond the kidney. You also can look at the liver, the bones, and all sorts of things that are kind of in the abdomen to understand, is there a spread beyond just the kidney. And then the other place that we always really look at is the chest. Renal cell carcinoma likes to go to the chest, so we typically like to get a chest CT scan of some sort to understand, is there anything concerning in the chest. So a CT scan, whether it be chest, abdomen, pelvis, or just abdomen, pelvis, gives us a lot of information about what your prognosis is and what the next treatment option is, right? So that's how we are able to tell what we need to do. And the routes that we can go from there really go between doing surgery or we talking about chemotherapy, right? And chemotherapy is usually reserved for patients who have disease that's spread beyond the kidney. If you have disease that is localized to the kidney, surgery really is probably the first line option for most patients. And I'm making big generalizations here,
Yeah.
but that's typically what the next step would be for people who are diagnosed with cancer just localized to the kidney.
Yeah, my insurance company, for some reason or another, had it in their head that I should be getting a biopsy as the next step, but my doctor and I dissuaded them. It's like, no,
Well, I
that's
can tell you, I mean, that's a whole different conversation. I can explain to you briefly why that might not be the case. And so the reason that we don't want to always biopsy these masses, and I'm not saying that that's not necessarily standard of care. It depends on really practice patterns around the nation. But if you look at the mass itself, the chance that this is a cancer, a solid mass that this is a chance that it's cancer, ranges almost 80 to 90%. So if you look at those odds, a biopsy really is not giving me any more information that me removing it would probably ideally do, right? And then even in that 20% of times that it may come back, kidney cancer is tricky. What it can do is there's could be portions of small benign tissue inside the tumor. They're very heterogeneous. So the worry that you have here is if you biopsy something and it comes back benign, how do you know there's not another area in that multifocality of a tumor that could actually be cancerous? So given all these reasons, we don't routinely biopsy renal masses. Now it doesn't mean that we don't every now and then, but for most places, I'd say at least in America, we tend not to rely on renal mass biopsy very often, and that's really the reason is it really doesn't add much more information.
yeah.
But you spoke to another aspect that I know we don't have the time to speak about in this conversation is why does an insurance company really involved in this conversation between a doctor and a patient, right? I
Oh
mean,
yeah, please don't take me down that
yeah,
line.
I
We
can't. I
will.
mean, I almost I couldn't take the opportunity not to talk about it and just explain how frustrating that is. There's some company that's not, I'm sure there's not a clinician involved in this who's not even part of your care team is saying that that's something that you need to do or should not do. And I'll tell you, practicing in America again, not the part of, not the topic of this podcast is. I just wanted to say it's becoming very more challenging because what I know is clearly standard of care. I order for our patients, and that could be imaging or PET scans or whatever we're talking about, and they're getting denied because for whatever reason the insurance company doesn't feel like that's applicable, and it's honestly it's becoming such a bad epidemic, and honestly our government really needs to figure out the best way to really reel in these insurance companies.
I'm just going to bite my tongue
Me too.
and,
That's the last I'll say on this topic.
and move
Because
on to the
again,
next
I
question.
just want to make sure that your listeners understand how challenging it is as a physician to
Yeah.
spend hours on the phone with insurance companies
You,
just to make
yeah,
sure
you
patients
have to
get done.
advocate for yourself. That's what I would leave this conversation with is
There's no question.
you have a care team and your doctor, you trust your doctor. He's a part of your care team. The insurance company is there to facilitate getting it paid for without it just taking you under. That's why we signed
That's
that
why we pay the
contract in the
premiums,
first
Alan,
place.
right? That's
Yeah.
why we do that.
And so
Anyways,
there's a deal. We need to go ahead and meet that deal. And they don't like this side of the deal, but
yeah,
that's the actuarial conversation that they had when they told you how much this was going to cost.
I know.
And we're answering that question right now. This is why we pay this. But that said, um, the interesting thing about cancer, and this is all cancers really, is that treatment is not just this get it out of me thing. Sometimes it's a wait and watch. Sometimes it's a cut a little bit of it, cut it out and leave the rest of the stuff there. And like in my case, it's radical nephrectomy.
Okay,
So it's the whole kidney has to go because of the size of this thing.
okay,
Um, let's talk a little bit about treatment.
sure.
What does someone expect when they're getting into this? How do they make this? How do they make the right decision for themselves? And then, beyond, because again, it's not funny thing, the interesting thing about cancer is that it's seldom a cut it and you're done, or do this one thing and you're done. There's usually a follow-on treatment protocol and some things that you should be doing.
Yeah. So let's talk briefly about treatment for renal cell carcinoma or kidney cancer, right?
Yeah.
So it depends really on the size. So let's talk about localized cancer. So it means kidney that's not a tumor that is not spread beyond the kidney, right? So cancer that's just in the kidney itself. There's really two major ways that we can approach those scenarios, and one's called a partial nephrectomy, and the other one's called a radical nephrectomy. So to start, a partial nephrectomy means you actually remove the tumor and maybe a very thin rim, millimeters of tissue around that tumor, but preserve the rest of the kidney in place, and you can, we essentially reconstruct the kidney back together, but we take the tumor out. That's the preferred option for tumors that are actually amenable to that type of surgery, right? You can imagine if a kidney, let's say, is about 12 centimeters or 15 centimeters, and the tumor is about 2 centimeters, and as long as it's in a favorable location, and for the most part, you can achieve that goal. You can take this tumor out and leave the kidney behind. In tumors that are much bigger or probably kind of are very close to the blood vessels, or for whatever reason we need to remove the whole thing, we do something called a radical nephrectomy, and that's where we remove all of the kidney and the surrounding tissue around the kidney, and we take it out of the body. Now, for most people, and I'm hopeful that's you as well, Alan, we have a normal, healthy contralateral kidney, and that's not the case for everybody, but for the vast majority of people, that's the case. And that kidney, as long as it's healthy, can compensate, and you can live a normal, healthy, and full life with one kidney. And that's actually why we donate kidneys to people, right? That's why we have a kidney donation program in this country. It's a bit different scenario, but that's typically why we can live with one kidney.
Yeah.
So that's why we really tend to want to either do a partial or radical. Now, there are some times when the tumor is so small, when the tumor is so small, and the patient may not be in the best surgical shape, like a great surgical candidate, there's a watch and wait method as well. And there's, kind of underneath that, there's all sorts of ablations or cryotherapy that we can use to kind of, keep the disease at bay if need be. But I think if you look at it in America, right, the vast majority of people will either get a partial or radical nephrectomy for their kidney cancer as long as it's localized. Now, I'm not going to go too in depth about the non-localized or the metastatic disease scenario, but I will say that for those we have really great therapies. It's mainly immunotherapy that we can use, where we infuse into the body and it's able to treat those multiple areas. So it's kind of like a chemotherapy, but it's kind of under that broad realm, but it's a bit more targeted, called immunotherapy. Now, I think you brought up one point. You said, well, it's rarely just a surgical removal and then you're done. You have to have some type of follow-up treatment. The good news for renal cell carcinoma or for kidney cancer is, for the vast majority of time, surgery is curative. So that's the good news, right? So, excuse me. So that's the good news. So we do still have to give chemotherapy or immunotherapy for certain patients after we remove their kidney, or I think rarely a partial nephrectomy. But I'd say the vast majority of times you actually don't need any further chemo or further radiation. So it's actually, in that regard, once you heal from that surgery, you're cancer free, which is the good news about kidney cancer, is it is, if localized, highly curative.
Okay. Now, as far as other, of course, like I said, I read a lot. I've read a lot.
Yeah.
Um, as far as things like nutrition and other things like that, is there some things that we should consider? Obviously, if you're obese, then you work on that. If you're a smoker, you stop that. But are there other things that I can do lifestyle wise that would put me in a better position going forward?
Well, I think the question is, what can you specifically do? And, if there was a magic pill or a magic drug or a magic, fruit that we'd all eat, and we'd say, hey, listen, we're all going to be healthier and be cured of all these diseases, I think that'd be awesome, right? But the reality is there's not, right? And so outside of regular exercise, healthy eating, and watching all of our medical comorbidities, whether that be diabetes, hypertension, obesity, those are all the things that play some part of all of this, whether it be kidney cancer or colorectal cancer, breast cancer, whatever it might be, right? And I think it's going to be really important as we move forward is, we got to probably eat less processed foods, watch our, intake of, other foods and fast foods and all sorts of stuff. And, potentially microplastics is kind of in the news now, that could potentially be a reason that people are having more cancers. I don't know if anyone knows the real reasons for those things, but I think outside of, like I said, eating healthy, exercising, and watching all of our medical comorbidities, there's probably not much more that we can do.
Yeah, in this world with all of the I guess we could call them technological advances and everything that we've added to our experience and our exposure and our environment, there's a lot of confounders in this little experiment we call life. So
There
finding the
is.
one thing is probably going to never happen, but just generally living a better
I
overall
agree.
lifestyle is
And
good.
I think, Alan, what the thing that I feel I get frustrated about is, you know, people in your situation that, recently diagnosed, and I think you're hopefully looking at, and from what I can gather, you're looking at really reputable sources. You're not just going to the internet and saying, hey, how do I do this? But that's a very vulnerable state that these people are, right? When you're diagnosed, you feel like your world is falling apart, and you're just like, like, my gosh, I have cancer, and you're just like grabbing for answers. And there are a lot of misinformation and just phonies on the internet that are hawking some type of pill or vitamin, saying that this is going to cure them, and it's really, really unfortunate. And I have seen firsthand people who've come to me with curable cancer. We could have done a 3 hour, 4 hour surgery, and they would have been cured. And they, for whatever reason, delayed treatment, and they went down to somewhere in America or somewhere in the world and got some vitamin therapy or whatever it might be, and they come back and now their disease has progressed, and it's so frustrating to see that. And there's no recourse for those people, and that's really the unfortunate part of all this. There's no recourse for the patient. The patient is obviously going to be, really end stage in the near future, and there's no real consequence to the people hawking those really terrible options. So I think my advice to anybody is, you got to find a reputable doctor, and typically one that sees a lot of these diseases that we're talking about, right? For your example, Alan, you were diagnosed with a kidney tumor. You obviously are going to go to a urologist who sees a lot of kidney tumors, right? You're not going to go to one that does not see a lot of kidney tumors, right? And so that's really the point. And there's colleagues like me, and people in my field who did further oncology fellowships specifically for urologic oncology. You know, this was an 8 year course for me to do what I do after medical school. So that's not a short amount of time to just sit there and do that. I've almost a decade's worth of experience after medical school, plus the years that I've been in practice. And I think when you add that up, 20 years of experience really hopefully shows when you see patients. And that's really what I tell you know patients and listeners here, is really find a reputable source. And I know that's challenging sometimes. It's hard to know what's
Agree. If
reputable
you're,
and
if
what's
you're
not
building
reputable.
a team, so get your all-star quarterback in there and win this game, right?
Yeah, that's really the goal.
So, Doctor, I define wellness as being the healthiest, fittest, and happiest you can be. What are three strategies or tactics to get and stay well?
Yeah. So I think I've said this, I think, a few times in this interview today, right? And it really just comes down to your physical, your emotional, and your mental health, right? And I think there's really the ways that we do that. When we talk about physical health, I mean, there's the obvious things of talking about, like reducing your drinking, no smoking, and exercising, and keeping your medical comorbidities in check, right? There's no question that that's probably the largest amount of things that we can do. I think as we get older, we have to go see primary care doctors. We have to make sure our cholesterol's on check. These are all so intertwined that it's really important that we keep a real close check on all of those things. And that's the important aspect of being physically healthy, right? Emotional and mental health can go together, right? I mean, when you say wellness is the happiest you want to be, I think we've all at times struggled with being happy, whether hopefully not chronically, right? But there's obviously people who struggle with that as well. But we can remember the times that we've gone through tough times, we weren't as happy, right? But that's not what wellness is, right? We really want to be able to have the best version of ourselves, and we have to be happy with ourselves for sure. That's always going to be a work in progress, right? I think anyone that says they're not trying to work to be a better person, I think that's something that they got to continue to work on, right? I mean, there's no question that that's going to be a large part of being well, is both being emotionally and mentally happy, as well as being physically fit as well.
Awesome. So, Dr. Yam, if someone wanted to learn more about you and what you're doing, where would you like for me to send them?
Well, there's I'm happy to see patients through our hospital, which is Hackensack University Medical Center. There's a bio online. We have videos about me. We've also recently launched a website for patients with kidney cancer called kidneycancerresourcecenter.com and or .org, sorry, kidneycancerresourcecenter.org, and that's a vetted source for kidney cancer information. So whether that be animations and videos about how to learn about kidney cancer, what is staging and how is that related, and what's an MRI, what's a PET scan, all of that's on one reputable source, and so they can really learn more there. Or I'm happy to see them in the clinic and really be able to help them in that regard too.
Well, thank you, Doctor. And thank you for being a part of 40 Plus Fitness.
Alan, it was really a pleasure. Thank you so much for having me today.
If you enjoyed today's show, take a moment to subscribe so you don't miss the next one. And if you would, please leave us a rating and review on your podcast player of choice. Next time on the 40 Plus Fitness podcast, we meet Dr. Jacques Mora Marco and Dr. Yoon Kim and discuss their book, Walking Your Way to Vitality, integrating walking, breathwork, and mindfulness into your daily exercise. Until then, have a happy and healthy week.